So the second talk today is Professor Kevin Munro is going to talk about the use of cortical evoked potentials to verify hearing aid fitting in young children. Okay, thanks very much.
Thank you. I was looking at this last night and realised that actually the title's not very exciting. So thank you for being here, probably here to listen to it. And Maria, I think if I get the chance to do this again, I'll find a more exciting title. But once I realised that, I thought I'd have to inject something a bit more exciting into it. So in the newspaper yesterday, there were articles about people using e-book readers. I don't have one. Some of my best friends have paperback books. But there's this trend, of course, towards people using e-book readers. And if you have one, you realise you can highlight quotes and you can put it on the internet, and everyone gets to see the quotes that are most common. And one of the ones that's high on the list is this one that we well known to some of you. It's the truth universally acknowledged that a single man in possession of a good fortune must be in want of a good wife. And if you're cultured, you will realise that that's from opening part of Pride and Prejudice and Jane Austen. If Jane Austen was alive today, and if she was an audiologist or a teacher of the deaf, she might have changed some of the words and said, it's a truth universally acknowledged that a newborn child in possession of a hearing loss must be in want of good early intervention. And that's what we're going to be talking about in this presentation this afternoon. That might make it sound a little bit more interesting than the words that were there previously. So in the UK, for almost 10 years now, there's a universal newborn hearing screening programme. So every newborn baby is entitled to a hearing screen within hours of being born. And the uptake or the coverage is something like 95%. And what this slide, and England was the first country in the world to have a universal newborn hearing screening programme. And what this slide shows is the age of hearing aid fitting before there was a newborn hearing screening programme, and now that we have a newborn screening programme. So before there was a programme, that's the red line up here. So this is the age of the individual when they first got a hearing aid. So 50th percentile, before we had newborn screening, was around about 15 months. And you can see there's a long, long tail going along here. The other two lines in this graph are both, now that we have newborn hearing screening, different data sets. And you'll see that actually it's a lot quicker now. That the median age is now down here. Actually, it happens to be around 80 days of age is when we now fit hearing aids to babies who fail the newborn screening and get referred on for diagnostic assessment. And the tail is somewhat shorter than it was before. So in terms of the achievement and performance of newborn screening, it would get an A plus or a gold star. The main thing we're interested in is not just can we detect and do something early, but is it making a difference when we do something early? So has it made it all worthwhile? And actually within the UK, there's not a lot of evidence, there's not a lot of studies that have been done, many studies have all been done, to look at the relationship between early intervention and outcome, which is somewhat surprising. But there is some work that's been done, and probably most notable is the work that's just come out of Australia, a study by Teresa Ching called the Lockyer Study, Longitudinal Outcomes of Children who are hearing impaired. And Teresa Ching and Harvard and her colleagues in Nal took advantage of different states introducing newborn hearing screening. So there were groups, there were parts of the country that didn't have newborn screening, parts of the country that did have newborn screening, but the services are provided by Australia Hearing, so the quality should be the same. But anyway, this kind of summarises the findings so far, and they have outcome measures for language at 5 years of age. That's the most recent ones, which haven't been published yet. So here's the age of fitting. This is the global score, and further up the graph, the better. And there's 3 different groups shown here for different severities of hearing loss, going from mild, moderate to severe. And you'll see there's an interaction. If you take the severe one down here, so hearing threshold is an average of 70 dB HL or greater, on average it makes a big difference to do something early, and there's a penalty for being provided with hearing aids or intervention late. That's for hearing aid fittings. This is a similar sort of graph, but this is for cochlear implants. And you'll see the same sort of pattern, and actually it's perhaps even more pronounced that in terms of average, you really want to, based on a language measure at age 5, you really want to be doing things way up here very early on. So there's some evidence from some parts of the world that actually early intervention, early detection is good, early detection can be achieved, and early intervention can make a difference, at least on some short-term language measures. So these children are not old enough to look at longer measures in terms of quality of life and educational attainment and whatever, but in terms of language is obviously important. But here's the challenge. So now we're doing things and fitting hearing aids on average at 8 days of age based on an electrophysiological measure, because there's nothing else we can do at that age. But then there's a delay until a developmental age of around typically 7, 8, 9 months before we're able to do behavioural measures. And no matter how happy we are with our electrophysiological measure, there's a potential that this is introducing a delay until we're able to reassure ourselves we think we've got the hearing aid set appropriately and the interventions correct. So the question really is there something that could help, not replace any of our measures, but something that could supplement what we already do, something we might be able to use from between 80 days of age up to, say, age 6 or 7 or 8 months. Actually, a third of hearing impaired children have additional disabilities, so developmentally, a third of them probably aren't ready at 6, 7, 8, 9 months to do these sorts of behavioural measures. So there's this potential delay that could do harm to the fact that we have newborn screening and we're putting hearing aids early. So, despite how good frequency-specific ABRs are, and that we have to rely on them, or something similar, ASSR maybe at an early age, here are some of the things that would make us think it may be helpful if we can find other tools to help supplement what we're already do. And one of them is, based on average, our estimated behavioural hearing threshold, not uncommonly, varies by 10 dB from what we predicted it would be from the ABR threshold, once we've taken into account any correction factors. We know that in a percentage of these children, it's been reported multiple times, that there could be a difference of 20 dB or so, and that could make a big difference to the gain and frequency response that we use from the hearing aid. We know when there's a severe hearing loss, we might not get any measurable ABR at all, but that might not mean that the individual wouldn't potentially benefit from providing them with a hearing aid that may still restore some degree of audibility. So that's still to be investigated. But we're having to fit hearing aids to individuals, sometimes when there isn't an ABR response at all. There might be middle ear disease or middle ear problems that complicates things, that can influence the detection or the hearing, the ABR threshold, and sometimes there are particular conditions where you can't get an ABR at all. So no matter how good we are at doing things like ABR, no matter how good our recording conditions are, there might be the need to kind of supplement with other things. And actually, if you ask families and professionals, as we have done, there's great enthusiasm for trying to find something that will fill this gap. So in the Northwest, we have something called the Children and Young People's Hearing Research Group. And if you go to that group and you ask the professionals, you ask the parents there, and you ask the professionals, they will say these sorts of things, that some indication that sound's getting through, that the hearing aids and they are being set appropriately, would be reassuring. Even if that's all we could do right now, is to demonstrate that something's getting through, that would motivate and reassure parents, because it's a tricky issue when you've got a little baby and you've got a hearing aid and it's whistling, and if there's not much evidence of any benefit in the early stages of providing the hearing aid, which often there isn't, then anything to help motivate and encourage you to persevere would be valuable. And the audiologists say the same sorts of things, that it might alert us that there might be something that isn't quite right in terms of the hearing aid fitting, or it might help us expedite for other strategies like the frequency lowering stuff that Anne-Marie was talking about, or cochlear implants. And you'll recall that Australian study was saying actually the best outcome happens as early as possible, as soon as you can get the implant fitted. And the British Society of Audiology has a special interest group that members can join, so people with a research background and clinical background can join. And there's a new group, an electrophysiological group, who are looking to bring together clinicians and researchers. And they're particularly interested in this, and they have a one-day workshop or meeting in Birmingham in January, looking specifically at some of the measures that might be possible to use at some point on individual children in a clinical setting. So what is available? Well, right now we have these functional measures, a questionnaire that we ask families to complete, and there's some evidence that they work well, except the child's wearing the hearing aid for a period of time before you can ask the family questions about have they seen differences in their behaviour to sound, for example. So good as they are, there might still be a need for something else. Behaviourally, we're limited in a clinical setting right now to a developmental age of, as you will know, 7, 8, 9 months, where infants are unsupported and turn their head for sound, and then normally get a visual reward. In research laboratories, there are techniques that are used to measure eye movements, which you can do developmentally before someone's able to move their head. The question really is it reliable enough to use in a clinical setting on an individual basis? And actually we submitted a grant on this a year or two ago, and we were unsuccessful, but it might be something that we want to revisit. But that brings us on to this topic of, might there be any electrophysiological measure we could use that would be a surrogate and might reassure us or not that a signal's getting through, that if it's being detected physiologically, there's a good likelihood that the individual is able to perceive that sound. And it could be, for example, something like the cortical auditory evoked potential, which we're going to speak a bit more about, that we're used to using routinely in the clinic to estimate hearing thresholds on adults, where there's some concern about the reliability of the pure tone audiogram. So we're used to using this measure. We don't normally use it, though, on infants and not individuals while they're wearing a hearing aid. So that might be one way of detecting is a response. And leading on from that, detection might be a good starting point. But leading on from that, it might be worthwhile if there were procedures that allow us to tell, can two different sounds be discriminated? And that might be using a cortical response or something called the auditory change complex. So the cortical auditory evoked potential has been reported around about the 1950s. There have been some reports going back a long time of measuring these cortical responses on individuals while they wear a hearing aid. And this, I'm not sure if it's the first one, but it's one of the first ones, way back when probably most people in this room were born, so in the mid to late 60s, on a hearing impaired child with a cortical response, without a lack of a cortical response, or not wearing a hearing aid, and then when wearing a hearing aid, the presence of a response. So this might not be the approach that we want to take now with the same stimuli, but people have been reporting doing this sort of thing for a long period of time. And there are bits of kit that are out there that are sold for using in a clinical setting to do these sorts of measurements. Lots of manufacturers are interested in them. There's one bit of kit that's been designed and marketed specific for doing these aided corticals from the NAL group. I just wanted to mention a couple of the things that's useful when we're doing these measurements on infants. One of them is it gives you a measure of residual noise. And that can be important because these cortical measures can be a bit tricky to identify in infants and vary a lot from one age to the next. So if you don't have a response, it's useful to be able to have a measure of noise, so you can say, well, how much importance should I attach to it? Was it very good recording conditions and I should attach a lot of importance, or was it rather noisy and we need to repeat the test, whatever. And it also comes complete with an automated response detection method. So there's a statistical package there that says this activity is statistically different from noise or from zero. So we actually chose to use this equipment for the preliminary study that I'm going to tell you about. It may not be the equipment we carry on using for future studies if we secure some funding. But we thought having these couple of things there might be helpful while we gain more experience. In recent times there have been a couple of relatively small scale studies published doing exactly this, using the same bit of kit as it happens, and testing children who have a hearing impairment. So both in the last couple of years, both on relatively small numbers, and what the authors or the researchers were doing there was looking for the presence of a cortical response to a signal of a conversational speech level and comparing that to the behavioural response. So obviously you can't do it on these young babies we're interested in, because we want to know, will this work between 80 days up to 6 months. So the only way of doing it in that age group would be to do the corticals and then at a later date do the behavioural measures, and of course that comes with complications that there could have been progressive hearing losses and middle ear problems and whatever. The alternative, and that's what one of these groups did, Van Dunder, was to do the measurements in an older age group, so you could do the behavioural measures on the same day and look at the relationship. But of course they are not the babies we're particularly interested in doing it. So Some interesting findings, some potential limitations. One concern really would be that in these babies where the researchers thought they had restored audibility, there are pretty big numbers that are not showing a cortical response. But actually, there's no information about retests, and at least one of the manuscripts they talk about not being experienced at doing these sorts of measures. So it's hard to know how much of it is because of that, or is it really that rubbish that 30–40% are not going to show a response, and what would that mean if we were to try to implement this in a clinic on a case-by-case basis? Anyway, as a precursor to doing this on hearing impaired children, we got some funding from the Central Manchester Strategic Research Fund, £100,000, to gather some preliminary data on normal hearing babies that we could then use to develop some external research-funded and grant applications. So our aim, and that's what we're in the process of doing right now, we've not quite got through 100 babies, and we've got through most of them, and the remaining of them will be tested by Anne and Marie hopefully over the next few months. So we wanted this age range from 4 weeks upwards. Actually, it's probably from 2 months or so, 80 days, up to 6 or 7 months that we're particularly interested in. And the questions are entirely driven by clinical needs, so applied research type questions. Is it feasible to do these measurements in the clinic? So can you take a little one and stick these leads on their head? Unlike ABR when you want them to be asleep, we're talking about doing this at maybe 3 or 4 or 5 months of age when you're taking a notice of things attached to the end and want to pull them off and stuff. So we wanted to know, well, how many could we complete these measures on? How long does it take to do the measures? Was there a response present? And these are normal hearing babies defined in they passed their newborn hearing screening and the parents don't have any concern. And how acceptable did the family find this? And there was a group of us involved in the study, and I'll show you everyone's name on the slide at the end with acknowledgements. So this is where we've got to. We've tested 7 to 8, or probably a few more than that. I think it's 80 now or something. Yeah. Numbers might have varied slightly. There were 3 babies that were either fast asleep and we couldn't wake them up, or we attached the leads to their head and woke them up and they couldn't settle down again. So there's 3 that we've lost at this stage. In terms of measuring how long does it take to do the test, we made some mistakes with the equipment for a couple, so we're not going to include them in the overall average of how long did it take, so that actually goes down to 73. And in terms of is the response present, we've put to one side the 9 babies that had flat tympanograms when we saw them. So this is the age range so far, and our plan is to have relatively equal amounts in each of these columns. You'll see most of them are, as it happens, probably in the age range that we're most interested in, but we do want to get, so Anne-Marie just joined this study, so here's the challenge now, that we'd kind of like to increase these ones here, well, they're hard to recruit and they might be sleeping a lot of the time, and these ones here who say, these leads look interesting when they give them a pro. But that's where we've got to so far. I thought I should at least mention in passing, for this preliminary study, we just accepted the stimuli that the Hear Lab comes with. We may not use these stimuli when we're working with our hearing impaired children, but this is information about the stimuli, and it's been extracted from running speech, t, m, and g, but very short duration, so actually it kind of sounds a bit like a clicking. You have to listen for quite a while before you realise actually there is a difference between these two. And one of them, they're all broadband, but the frequency emphasis is different, so m is down here and t is up here. But we have a grant that actually we're waiting to hear the outcome from NHR this month, and fingers crossed if we're successful, one part of that grant and the part that Michael Store will be leading, we'll be looking a bit more closely at the stimuli that's appropriate to use for aided testing. And in particular, we just want to make sure that there's no interaction with the stimuli in the hearing aid that might affect our response. So is the hearing aid gain operating correctly when we're recording these? Essentially it's an onset response that we're recording. The hearing aid isn't being thrown in any way and changing because it thinks it's like the noise reduction should be used or whatever. Okay, so what have we found so far? We've completed the test in more than 95%, so that was, I'm very pleased about that, but there was a big doubt before we began. I wonder how many of these kids you can actually do this on. In terms of test duration, not really that different from the sort of procedures that we do in a paediatric environment right now. So on average, or median is 20 minutes. Huge range, of course, as you can see, from right up to 8 to 9 minutes. So not much different from what we'd find acceptable in a paediatric clinic right now. Half the time is kind of explaining to the parents what you're going to do, and the other half is data collection, depending on how settled the infant is. This just gives you a feel for Mike Maslin's help here, averaging the response across subjects, so you can see what does it look like for a NIT or a TIN. First thing is they don't look that different, but it looks very different from an adult cortical response, where we normally look for an N1 at 100 milliseconds. And at this younger age, with the settings that we're using and characteristics, tends to be a peak, a positive response around about 200 milliseconds. So we've got a bash at measuring things like latency and amplitude, but actually we haven't done that in a systematic way yet, so we still have to do it. So, first of all, just based on visual detection, what have we been able to observe? If we come to the graph at the bottom, this is what percentage of these kids have a response to all 3 stimuli, what are the response to 2, how are they response to 1. So you'll see that about roughly 3/4 have a response to all 3 of these stimuli, and almost all have a response to at least 2. And that's it separated up the top. So something between in excess of 80% up to 95% detection for each of the 3 different stimuli that were available for us to use on this piece of equipment. A little bit complicated, but I'll just take you through one corner of this slide. So we've yet to do this systematically, but when we take our first run of 75 accepted sweeps, we've categorized it as we can see a response or not. Now we're biased because we know they're normal hearing babies and we'd expect to see a response. So in our next study, if we get the funding, there are things that we're doing to avoid doing it. And this is what did the automatic scoring, the statistical package show. So if we just take this one up here for NIT, on 3/4, they both agreed for yes and yes, another 10% or so both agreed for no. So these are the ones where there was disagreement. So roughly 25% didn't agree between the 2 measures. So actually another part of our grant that's in right now is to look more closely and working with colleagues elsewhere at Southampton in terms of identifying the most appropriate statistical detection method and looking at the relationship with visual detection by experts. We asked the parents some questions and they were interviewed. Kai took responsibility for this part. So this is it's a little boring because we're all pretty happy with what we did, but these are parents who are not necessarily concerned in any way and were happy to come along as volunteers. So they were asked questions about, and I'll just paraphrase the wording so it would fit on the slide here, what do you think the way the procedure was described, whatever. And a small number means it's pretty favourable and they're unconcerned, whatever, and a big number means that they were. And as you can see, they're all pretty low numbers. The one that's the highest of them all, but still low, is the need to keep the little baby still and awake but not too restless for doing the testing. And Kai carried out some other qualitative stuff. It's a day of culture, so here's another literary quote that Kai gave me. All happy families are alike. Each unhappy family is unhappy in its own way. And all of these normal hearing baby families, we're all happy. So yes, again, we're happy. So nothing very much to report from this group. That may not be the case if there's been some concern raised because you might be hearing impaired and have a hearing aid, so it might be a bit different. We also had a look at the location of these recording leads, because routinely we use most activity for cortical response is just forward of the vertex and we record it between vertex and mastoid. But when you've got little babies and fontanelle soft spots in hair, there's a tendency to say, let's just go for a high forehead. So we wanted to know, and that would make it a lot easier in the clinic, is there much difference in the detection of responses if we use a high forehead versus a vertex? This is kind of preliminary work, so just take it with a pinch of salt. But what you'll see is actually there's a bit more noise at the vertex, but actually there's also a bit more signal. So the signal to noise ratio doesn't differ a lot between the 2 positions. If anything, it looks to be signal ratio is not quite so good on a high vertex, and that would mean you'd have to record for a longer period of time And typically for our parameters it would be an extra 30 seconds or so, which might be acceptable. But we're doing some more testing here to decide, is there much difference, or could we just say use a high forehead for these sorts of measures. The next steps then, we have to finish gathering the data from the preliminary study. If we're successful with our grant, or if not, we'll have to submit it somewhere else. These sorts of things that I've mentioned on the way along, some kind of early implementation work, so looking at the sort of stimuli, looking at the statistical detection procedures that we've used. And then we're particularly interested in what is the relationship between audibility and the detection of one of these cortical responses under good recording conditions. So is it possible to detect a response? Because they're a bit concerned that these other studies that have picked us to the post that came out in the last couple of years are saying maybe 30 or 40% what a response. So our plan is to do these cortical measurements twice, so we have a test and a retest, and to do the behavioural measures twice, a test and a retest, and to be as rigorous as is possible within the constraints of a clinically applied project and working with little people. And if we happen to get all that done, and it is successful, it might not be, if it is, we then want to go on and look at some of this discrimination stuff. I thought I would just end with this information to show you how important clinical people, and there's some here today, value this. We contacted all the paediatric clinics in England to say, this is something we're thinking about doing, might you be interested in supporting us? So we don't know exactly how many there are, because some do diagnostic tests but don't fit hearing aids, but around 128 of them. And you'll see that big number, 87% have responded, and 80% of them all have said, yes, we'd like to support you and get answers, because this is obviously very important to us. So that's kind of a marker of how important and clinically relevant this sort of project is. These babies, of course, are born all over the country. They're not all born in Manchester. Not at any one time there's only 2 or 3. So within the time that's available to do the study, we probably have to go to them. And when we spoke with these parents and professionals about, okay, if we come to you, but one of the families said, well, you say come to our local centre, but actually it's not that local, it's not that convenient, we can't get parked and whatever. So with some suggestions from Michael Stone, actually, we're getting lots of mentions today, Michael, and then discussing with the families, they were quite keen that actually if you had a mobile unit that came to us, well, we definitely want to join your study. So we've been fortunate that we've got a gift, that if we get a grant, to have a unit that will have appropriate sound treatment, so that whoever we employ as the researchers will drive around the country and stop in lay-bys, and no, not stop in lay-bys, stop outside houses or at appropriate places to gather this data. In terms then of take-home message, based on these normal hearing babies, we have a remarkably and somewhat reassuringly a high completion rate, high response rate, that appear to be acceptable test duration, and acceptable to parents of these normal hearing babies. So I just finished by acknowledging people who've got funding from SOFA, so from the Central Manchester Trust, Martins for the unit. These are individuals mostly who are named on the grant for the preliminary study or are named on the next grant we're waiting to hear the outcome of. And some industrial companies are interested. Lots of them think it's probably time we should be implementing this aided cortical stuff, because we're always getting asked about it. So some in particular have been discussing with us about maybe getting involved in our study, maybe providing some equipment, maybe implementing what we do in their equipment. Okay, thank you. There's no one knocking on the door yet, but there probably will be soon.
Yeah. Time for a quick couple of questions.
I have a quick question. One of the things that I'm really struggling with is how to sometimes interpret the corticals. If it's very clear cut, then it's easy peasy. But let's say especially with patients, when sometimes you have, let's say, different speech stimuli, and you have responses in some and absolutely no responses in others. And I think this is an overall sort of struggle to. Can you comment?
Yeah, so we've used these stimuli that have been extracted from speech in our preliminary study. It doesn't mean that's necessarily what we think is the most appropriate if we're doing hearing impair. I mean, in some ways, what we want is a bit like an audiogram. So you might take kind of relatively narrow frequency regions, so you can say, well, the high frequencies appears to be audible, at least in terms of getting a physiological response. The mid frequency is too. I think the statistical detection method is an important one, because it varies so much from one person to the next. But probably you can't eyeball it in the way that you would an adult cortical and say that there's a response present or there isn't. So I think that's quite an important part that we've got in the grant to say, what are the statistical methods that might be available to us? Do they agree, don't they? Do they agree with an expert? Exactly.
Sorry, you mentioned earlier, I just wanted to ask, you brought up a slide about cochlear implants, and you mentioned earlier about the influence a lot of the children that have hearing loss also have other cognitive delays.
Right, yeah.
Were they accounted for in that slide, the cochlear implants? Was that just
Yeah, so, right, yeah, that's a good question. So it's not our data, that's a slide that's come from Australia.
Right.
Yes, they've taken it as, these are individuals who've come to get a hearing aid, so a percentage of them include people who have multiple disabilities, so maybe around about 1/3. And of course that might also influence the outcome on that scale, that's not just a hearing impairment. Yeah.
I was wondering, moving forward, would you take that into account for the next study you're planning on doing when you're actually testing hearing loss children to see if there's
Well, we certainly should take it into account if we recruit individuals who have multiple disabilities. Yeah, and maybe display the data separately so you can see the effect if there's more than just a hearing impairment. Yeah.
Obviously, it makes sense that you're discounting people with flat tin. With the age groups that you're testing, though, what frequency are you doing your tinnitus at?
Yeah, so it's actually Ruth Nasser who was collecting this data, who's now working with you. Yeah, we had high frequency TIM for the younger ones. Yeah, so we're not throwing them out altogether. I want to, so it's helpful that I can just clarify this. What I meant was, when we look at the presence or look to say what is a representative range for latency and amplitude, we thought we better not include the ones that have got flat tints in it. Yeah.
You went through some of the difficulties with collecting data from these children, keeping them attentive and still. Why did you decide to keep having them awake? Because you would get a response if they were asleep. Would that remove some of these compounds?
Yeah. Well, because I don't want to get into the controversy of doing corticals when someone's awake or asleep, but given that these infants on average will be at least 80 days of age, they will be awake when they're wearing their hearing aids and coming to the clinic, so it makes sense that we try and gather data under the normal condition. If we said, actually that's not at all possible, but hey, we could sedate them and the parents wouldn't mind, it might be, we do want to try and do things when they're asleep, but it was really just saying, we want to relate this to the clinic because there's a need to do this. Yeah.
Okay, thank you very much.